Now the next one is the 17-hydroxylase deficiency. After completing the 11-beta deficiency, we are moving on to 17-hydroxylase deficiency, which is otherwise referred to as 17A1 deficiency. So obviously, what will be the inheritance pattern? The inheritance pattern is going to be autosomal recessive. I told you all of them will be autosomal recessive, and the gene is CYP17A1. There is no doubt about that, and it is present in the chromosome number 10. Clear? So now let us see the pathophysiology behind this 17-hydroxylase deficiency. So we know that 17-hydroxylase deficiency is a common enzyme, so which means it's going to be a common enzyme for both gonads as well as the adrenal, which means it's going to affect both gonadal as well as adrenal steroidogenesis. Very, very important point. It's going to affect both gonadal as well as adrenal steroidogenesis. Clear? But what you will be having paradoxically here is because in 11-beta hydroxylase deficiency as well as in 20-hydroxylase deficiency, you saw increase in the 17-hydroxy derivatives. But here, as the name suggests, this 17-hydroxylase deficiency, you cannot form 17 based compounds at all, because this hydroxylase and lyase are almost the same. It's coming from the same gene. But in the fasciculata, in the zona fasciculata, you have more of a hydroxylase activity, and in the reticularis, in the zona reticularis, you have more of a lyase activity. That's all, nothing else. But apart from that, both are from the same gene and they are the same enzyme in fact. So and it's a common enzyme. That's very important. It's going to affect both gonadal as well as adrenal steroidogenesis. But very importantly, this 17-hydroxylase deficiency cannot produce this 17-hydroxy derivatives at all, and they cannot produce this 17 ketosteroids as well, which means their levels will be seriously suppressed. This is one of the contrasting differences from the previous deficiencies which we saw. Here the 17 based compounds cannot be formed at all. Very important. So because the 17 based compounds are low, obviously your adrenal androgen output is seriously impaired. At the same time, your gonadal function seriously takes a hit as well, which means your gonadal steroidogenesis also will be seriously suppressed, because you cannot produce this androstenedione without this 17-hydroxylase enzyme. Clear? So which means, like the most significant thing is the drop in the testosterone. So estrogen doesn't matter in fetal period, because even in the absence of estrogen, the female child will normally grow. There's no problem here. But these children, especially if they are male, they are going to suffer from low estrogen related undervirilization and DST. We'll discuss that in some time. But what will happen to the cortisol? Obviously, this is a no-brainer. Cortisol definitely will be suppressed, because the low cortisol, it's going to stimulate the pituitary and you're going to have a high ACTH. There's no doubt about that. Clear? So this high ACTH is the one that's going to drive the adrenal mad, and this excessive ACTH is going to stimulate the adrenal glands, causing hyperplasia as well as hyperpigmentation in the child. So this high ACTH is not only important for hyperplasia, it's also going to stimulate the available pathways. So what are the available pathways here? This glomerulosa pathways are still available. They are going to stimulate these pathways, producing excessive accumulation of this pregnenolone, progesterone and deoxycorticosterone. Remember, this pregnenolone and progesterone I don't want, because they are not going to cause any much effects in the child in the womb. But this excessive deoxycorticosterone is definitely important, because this excessive DOC is going to produce salt retention. Because in the fetal period and in the early neonatal period, this DOC is a very good mineralocorticoid. So they are going to produce salt retention because of the excessive DOC, and they are going to produce hypertension as well. But what will happen to the corticosterone and aldosterone? So corticosterone and aldosterone, by previous example of 11-beta hydroxylase, you will be thinking that they will be suppressed. But what if I tell they will be increased? There will be increased corticosterone, only 18-hydroxycorticosterone and aldosterone will be suppressed. You will be quite confused, isn't it? So you will be asking, sir, what, sir? In the previous example only, you told this increased salt retention and hypertension will produce suppression of renin. This is called low renin hypertension, and this will result in lower angiotensin II levels. This lower activity of angiotensin II will result in suppression of this aldosterone synthase. If aldosterone synthase is the one that mediates these steps, how can you have a high corticosterone? So yes, that's a serious confusion. These patients will have high DOC with high corticosterone, but low aldosterone, for sure, no doubt about that. And low aldosterone is due to suppressed aldosterone synthase enzyme only. But how come you have a high corticosterone alone? Be very careful. In the beginning itself, I told you this deoxycorticosterone to corticosterone conversion is mediated by aldosterone synthase only by its 11-hydroxylase action. And corticosterone to 18-nitroxycorticosterone, conversion is mediated by aldosterone synthase only, but by its 18-hydroxylase action. And 18-hydroxycorticosterone to aldosterone is mediated by aldosterone synthase only, but by its synthase action. Clear? So the same enzyme has 3 different functions, 3 different activities, and 3 different actions. So to convert this deoxycorticosterone to corticosterone, you need this 11-hydroxylase activity of your aldosterone synthase. But here the aldosterone synthase enzyme is suppressed. I am not denying that fact, but you can see in this condition the 11-hydroxylase activity of fasciculata is still intact. And with excessive ACTH, in fact, this activity will be even more higher because ACTH tries to stimulate this enzyme. So what's going to happen really? You know the blood supply of the adrenal gland is going to be radial. So if you take the adrenal gland, this is the medulla and this is the cortex. The cortex, we know it starts from glomerulosa, fasciculata to reticularis, and we know the blood supply flows from cortex to the medulla, which means in the glomerulosa, we know very well there will be excessive amounts of deoxycorticosterone, and this excessive amounts of deoxycorticosterone will be flowing to the fasciculata through the radial blood supply. And once they come to the fasciculata, in the fasciculata, you know, you have a good amount of 11-beta-hydroxylase. In the previous example, you had a deficient 11-beta-hydroxylase. So the conversion of deoxycorticosterone to corticosterone is not possible. But I can tell here, this 11-deoxycorticosterone can utilize this 11-beta-hydroxylase activity of the zona fasciculata, and they can produce excessive amounts of corticosterone. Clear? So that is how these patients will have excessive corticosterone. This is a very important, crucial concept to understand. Clear? So let us go back and see what will happen to the mineralocorticoids. If the mineralocorticoids are increased, so what are the mineralocorticoids that are increased here? DOC is increased as well as corticosterone is also increased. But remember, aldosterone levels will be suppressed. Glucocorticoids definitely low, cortisol is low, there is no doubt about that. And that's the reason why ACTH levels are high, and this is the reason for hyperpigmentation and adrenal hyperplasia in these children, obviously. But remember, these neonates, at birth at least, they will present with hypertension and salt retention because of the excessive mineralocorticoids. But later on, because aldosterone levels are actually low, they may not sustain over time, and they can go for small amount of salt wasting in their growing period. But at least in the birth, they will be having hypertension and salt retention because of high DOC and corticosterone levels. And what happens to the adrenal androgens? Here the adrenal androgen output is very low because 17 ketosteroid output is not happening without this 17-hydroxylase enzyme. And since this is a common enzyme for both adrenal and gonadal steroidogenesis, your gonadal function will take a serious hit. So definitely you will have a low gonadal function. So what will happen as a result? So these children are producing low androgens, both from the adrenals as well as from the gonads, if at all if it's a male child, and they are going to produce low estrogens as well. What will be the net effect in the female and the male child? So in a female child, it's a XX karyotype. So obviously they don't need androgen, they don't need estrogen for their external genital and internal genitalia at birth at least. So they'll have a normal development at birth, which means female children will not have any DST. But even though later in their life, they can go for delayed puberty. That is because they cannot produce estrogens. That is the reason later in their life they can go for delayed puberty. But apart from that, at birth they will be completely normal. They will not be having any genital related issues or internal genital related issues. But whereas in a male child who is having a XY karyotype, obviously this male child needs this sufficient amount of androgens from the testis. But since this is a common enzyme for gonadal and adrenal steroidogenesis, the male child will not be able to produce good amount of androgens. Because of the same, they will be under-virilized. They will not be properly virilized to produce labioscrotal fusion and single urethral opening, and they might result in ambiguous genitalia, but we are going to call that as a DST. which means this 17-hydroxylase deficiency is a condition that's going to produce a XY DSD, not a XX DSD, which means this 21-hydroxylase and 11-hydroxylase is going to produce a XX DSD, whereas this 17-hydroxylase is going to produce a XY DSD and not a XX DSD. That's very, very, very important. Here the female children are completely normal. So what will be the effect on external genitalia? I can reiterate the fact that female children will not have DSD even though they can have a delayed puberty because of low estrogen production from the gonads. But male children will have DSD, ambiguous genitalia, because of the under-realization due to low testosterone production in the embryonic period. So plasma-laden aldosterone activity will be suppressed because of hypertension and salt retention due to high mineralocorticoid activity. That's why it's called a low renin hypertension. And what are the metabolites that are increased? We all know very well that progesterone, pregnenolone will be increased, but the most important metabolites that we are going to measure is deoxycorticosterone and corticosterone. Both will be elevated here. But whereas your aldosterone levels and 18-hydroxycorticosterone will be suppressed along with cortisol, along with all 17-hydroxy derivatives like 17-hydroxyprogesterone, 17-hydroxypregnenolone, all the 17-hydroxy derivatives will be suppressed, and 17 ketosteroids like DHEAS and androstenedione also will be suppressed. This is a very, very, very important thing to understand. Remember, in 11-hydroxylase, only DOC will be increased, whereas corticosterone and aldosterone will be suppressed. Whereas in 17-hydroxylase deficiency, DOC and corticosterone both will be increased, only aldosterone levels will be suppressed here. Clear? So these are the pathophysiology and clinical features of 17-hydroxylase deficiency. Now let us see the 3-beta-hydroxysteroid dehydrogenase deficiency. What will happen in these patients? So 3-beta-hydroxysteroid dehydrogenase, once again, as I have marked here, it's a common enzyme. You can see that is needed for both adrenal and gonadal steroidogenesis, which means it's going to reduce adrenal as well as gonadal steroidogenesis. It is a little complicated to understand, but not so complicated, because till now what we have seen is the P450 group of enzymes, the deficiencies. 20-hydroxylase is a P450 group, 11-hydroxylase is a P450 group, and even the 17-hydroxylase is a P450 group. But now we are entering the hydroxysteroid dehydrogenase group. HSD is something different in lot many ways. Like I told you, they have isoforms. That is the point here. So they have isoforms in the periphery. So here, if I tell the deficiency of isoform 2 means it's only the deficiency of isoform 2. You have to assume that the isoform 1 is still normal, that is located somewhere in the periphery. So that's a very important basic point to understand before starting this 3-beta-HSD deficiency in the first place. So obviously it's going to reduce both adrenal as well as gonadal steroidogenesis, there is no doubt, which means your cortisol production will be seriously suppressed, no doubt about that. Your deoxycorticosterone will be seriously suppressed, corticosterone will be seriously suppressed, aldosterone also will be seriously suppressed. There is no doubt about that, which means your mineralocorticoid levels are low, the glucocorticoid levels are also low. Obviously, this cortisol that is suppressed is going to definitely stimulate the pituitary to produce excessive ACTH. And I need not tell again and again, but still I can do this all day like Captain America. So I'm going to tell again and again, increased ACTH is going to cause hyperplasia of the adrenal glands and they're going to produce hyperpigmentation as well. This high ACTH is important for stimulating the available substrates and products that are whatever it can do. So here, what are the substrates that can be stimulated? So this pregnenolone production will be accelerated, 17-hydroxypregnenolone production will be accelerated, and DHEA production and DHEAS production will be accelerated, because this DHEA invariably will be converted to DHEAS in the zona reticularis, because zona reticularis has very high activity of this sulfonyl transferase. That is the reason why usually DHEA is released very little. Most of the DHEA will be released in the blood in the form of DHEAS only, because of high sulfonyl transferase activity. So obviously DHEA and DHEAS levels will be high. But remember, what is the function of this 3-beta-HSD? Go back to the basics of the steroidogenesis. I told you clearly, the main function is to convert this delta-5 steroids to delta-4 steroids. So which means the delta-5 steroids will be high, but you will assume that the delta-4 steroids will be low. That's what you have to assume, isn't it? But it's a bit complicated. Not complicated. If you understand the concept clearly, it's not complicated at all. But the delta-4 steroid levels can be completely normal or even can be mildly increased. which means the 17-hydroxyprogesterone levels can be normal or mildly increased, and androstenedione is again a delta 4 steroid, which can also be normal or mildly increased. Once again, you'll be like, how is it possible? Like you have a 3-beta-HSD deficiency, which has to convert this 17-hydroxypregnolone to 17-hydroxyprogesterone. But if it is deficient, how in the world you can have a normal or a mildly increased 17-hydroxyprogesterone and androstenedione? You will expect a suppressed levels of 17-hydroxyprogesterone and androstenedione. But that is where the basics come into play again. I told you this hydroxysteroid dehydrogenase enzymes group has isoforms, which means only this type 2 isoform is actually deficient, but the type 1 isoform is still intact in the periphery somewhere, which means I can write this 17-hydroxypregnolone and this DHEA using this 3-beta-HSD1 enzyme in the periphery, even though they are not having high capacity to handle all this, but still they have a decent amount of capacity which can actually convert this 17-hydroxypregnolone to 17-hydroxyprogesterone and this DHEA to androstenedione, which means this is a condition of androgen excess only. So this patient is having a condition of androgen excess. I mean, not the entire androgen, at least adrenal androgen is in excess in these patients. Clear? So this is a very crucial thing to understand, because in the diagnostic point of view also, you are going to compare the ratio of delta 5 to delta 4 steroids for confirming this disorder. It's a very difficult disorder to confirm because 17-hydroxyprogesterone can be even marginally elevated. That is because of the action of the peripheral 3-beta-HSD type 1 isoform. So that is why I told in the beginning itself P450 versus HSD group of enzymes and what way they are differing in the previous video itself. If you have not yet watched, please go back and watch the video, which is very beautiful. But thinking that this 3-beta-HSD2 is a common enzyme, it is needed for adrenal as well as gonadal steroidogenesis. Your gonadal steroidogenesis is going to take a serious hit. So in what way they are going to take a hit? So they are going to have reduced the synthesis of testosterone, because you need this 3-beta-HSD to produce sufficient amount of testosterone in the gonads. So you are going to have produce low levels of testosterone in this children as well. So this gives rise to a very, very complicated scenario. Let me discuss in some time. So what are the final effects? Your mineralocorticoids are decreased, glucocorticoids are low, ACTH levels are high, adrenal androgens are actually increased because your DHAS levels will be very high, delta 5 steroid, but delta 4 steroids like 17-hydroxyprogesterone and androstenedione A4 can be normal or even mildly increased. So overall adrenal androgen output is high and testosterone levels are decreased because this 3-beta-HSD is very, very important for gonads. So there will be a problem in the gonadal steroidogenesis also. So what will be the net effect? So let us go back and see. Inheritance, definitely it's autosomal recessive, no doubt about that. Gene, it is HSD3B2. It's not a P450 group. It's not a CYP group. So it's HSD3B2, only 3B2, one is still normal. Isoform 1 is normal. Mineralocorticoid levels seriously suppressed and glucocorticoid levels also seriously suppressed. Because of the mineralocorticoid loss, these patients and these children will be having salt wasting, no doubt about that. And low glucocorticoids will result in poor feeding. And coupled with this mineralocorticoid loss, they are highly prone for adrenal crisis, shock and death in the early neonatal period, around 7 to 14 days mark, like 21 hydroxylase deficiency. And what will happen to the adrenal androgens? Adrenal androgens is increased here. And this leads to a unique condition where gonadal function will be suppressed. Clear? So what is the net effect? Net effect is the fact that androgens you can divide into two. That is, adrenal androgens will be increased, but the testicular androgens, if it's a male child, it will be decreased. Estrogens, we don't have a problem. Estrogens will be decreased as well, but that's not a problem as far as the fetus and the childbirth is concerned. So now, what will be the net result? In a female child, any form of androgen excess, it's going to virilize the female child and it's going to result in ambiguous genitalia and DST. So here the adrenal androgens are high in the female child. So this, irrespective of the estrogen, doesn't worry about, the female fetus don't worry about estrogen at all. So because of the high amounts of adrenal androgens, this is going to virilize the female child and they're going to present with a XX DSD as well, because female means XX karyotype. So they'll be coming with ambiguous genitalia. Whereas a male child, so the adrenal androgen levels are high. I'm not denying this fact. So DHA and androstenedione levels are high, But as I told you, these are very weak androgens, but virilization of the male child and the proper production of the external genitalia and internal genitalia of the male child is dependent on the testicular androgens. It's not the adrenal androgens. So here the testicular androgens are very low. And the adrenal androgens, even though they are raised, they are not sufficient enough to cause proper virilization of the male child. So a male child will result in under-virilization. Under-virilization, which means even a male child will have a DST, which means it is a condition that will result in XY DST as well. Which means 3-beta HSD is a unique condition where you'll have both XXDSD as well as XY-DST, where the female children will be over-virilized due to excessive adrenal androgens, whereas the male children will be under-virilized due to loss of testicular androgens. And over time, these female children later in their life may go for either virilization or a delayed puberty. Both can happen depending on what is the status that is happening in the puberty, but that doesn't matter. Both these male and female children with 3-beta HSD deficiency will have DST, that is disorder of sexual differentiation, or called as ambiguous genitalia. So what is the effect on the child? Female children, DSD, XXDSD for sure. Males, again, XY-DSD. This is because of excessive adrenal androgens. This is because of loss of testicular androgens. Very unique condition, very easy to understand. ACTH obviously will be raised because of low glucocorticoids. There is no doubt, and these children will have hyperpigmentation for sure and adrenal hyperplasia for sure. Plasma activity and angiotensin II activity, obviously it will be increased because this is a salt wasting state, volume loss state, so definitely that will be raised. So what are the metabolites that are increased here? The sure shot metabolites that are increased in this condition are 17-hydroxypregnenolone. There is no doubt about that. 17-hydroxypregnenolone will be increased, which is a delta-5 steroid. We know that. And DHEA and DHEAS will be increased, which is again a delta-5 steroids. What are the things that are decreased? Obviously, your DOC will be decreased, your corticosterone will be decreased, and aldosterone also will be decreased. No doubt about that. And cortisol levels also will be decreased. But what will happen to the delta-5 steroids? I mean delta-4 steroids. But remember, delta-4 steroids like 17-hydroxyprogesterone and androstenedione, as I told you before, they can be normal or even mildly increased. That is due to activity of the peripheral 3-beta HSD1 enzyme, 1 isoform. Fine. So how will you diagnose this disorder? So because the 17-hydroxyprogesterone levels are variable, I mean, you might have confusions with other disorders. So that is the reason why the best diagnostic test for this disorders, I mean for this 3-beta HSD deficiency, will be taking a delta-5, delta-4 ratio. You can take urinary delta-5, delta-4 ratio. In general, you can take a 17-hydroxypregnenolone, which is a delta-5 compound, to 17-hydroxyprogesterone, which is a delta-4 compound. If you take the ratio, this will be increased. So this is the gold standard biochemical confirmatory test. Even though if you have doubt, you can go for genetic testing always. But biochemical confirmation gold standard is this delta-5, delta-4 ratio, or otherwise I can tell 17-hydroxypregnenolone to 17-hydroxyprogesterone ratio, which will be raised for sure. Clear? So this is about the 3-beta HSD deficiency. So now we have the POR deficiency, or otherwise referred to as POR deficiency, or otherwise referred to as P450 oxidoreductase deficiency. I told you already this P450 oxidoreductase is important for the proper functioning of 3 different enzymes. One is this 21-hydroxylase enzyme. Second is the 17-hydroxylase enzyme. Both lyase as well as hydroxylase activity. For 17-hydroxylase, this enzyme is, this P450 oxidoreductase is very important. At the same time, this P450 oxidoreductase is important for this aromatase activity also. So for proper functioning of 3 enzymes, one is aromatase, then 17-hydroxylase and lyase, and 21-hydroxylase. For all these 3, you need good functioning of this P450 oxidoreductase. So that is why P450 oxidoreductase problems will result in problems that will have a mixed picture of deficiency of all these 3 enzymes. So they will result in a very peculiar state. Like they will produce again a state of maybe excess androgens in females and loss of androgens in males. So that is the reason why they can result in both XX as well as XY DST. You can remember that's a combination of like 21-hydroxylase and 17-hydroxylase. You know 21-hydroxylase is going to produce XXDSD and 17-hydroxylase is going to produce a XY DST, isn't it? And delayed puberty in females. And aromatase deficiency is going to produce maternal virilization. So they will have all the features. Like for example, this P450 oxidase deficiency will have a XX DSD. They will have a XY DSD as well. At the same time, they will have delayed puberty in female children, delayed puberty in female children as well as male children, because they'll be in a state where the sex hormones are not sufficient. At the same time, they are underproduced also. So there will be a scenario like that. So there will be delayed puberty. It's a combination. That's what I'm telling. At the same time, they'll be having history of maternal virilization. So why history of maternal virilization? This is a sign of aromatase deficiency. I told you in the previous basic videos itself, aromatase deficiency is one of the important pointers for aromatase deficiency is history of maternal virilization. So it's a combination. So you'll have different combinations. Salt wasting depends. They may or may not have. And cortisol deficiency again is variable. But in general, they will have a low cortisol usually. And this low cortisol will produce high ACTH. And this high ACTH will produce hyperplasia of the adrenal glands and hyperpigmentation in the patient's body as well. So, but it's a very variable condition. It's very complicated, but still you have to understand it's going to mimic deficiency of 3 different enzymes, that is 17-hydroxylase, 20-hydroxylase and aromatase deficiency as well. So let us move on to very rare forms of congenital adrenal hyperplasia. What are the rarer forms? Like star deficiency. You know that star is important in bringing the cholesterol faster towards the reaction zone, that is the mitochondria. So the first reaction, that is the side chain cleaving step or desmolase step, is happening in the mitochondria. So the star is the one that brings the cholesterol molecules faster towards the mitochondrial reaction site. So suppose if you have a star deficiency, first thing that happens is reaction will be slowed down. So how much it is slowed down? So this is called first hit. First hit means first step in star deficiency patients will have a slowed down reaction speed by 17%. So which means only 17% of the steroidogenesis will happen, number one. So which means they are not going to have steroidogenesis at all. Only 17% will happen. So this cholesterol that is brought very slowly over time will start accumulating. So this cholesterol will start accumulating within the steroidogenic areas, so like gonads and the adrenal glands. Once they accumulate, they produce a typical type of hyperplasia called a lipoid hyperplasia. That is the reason why this type of star deficiency related adrenal hyperplasia is called congenital lipoid adrenal hyperplasia, because this cholesterol accumulation in the adrenal gland will result in this accumulation of fat droplets in microscopy that you can see. So that's called a lipoid type of congenital adrenal hyperplasia. So this accumulation of this cholesterol in the gonads as well as the adrenal glands will start slowly destroying the glands. This is called second hit. Second hit will result in destruction of the steroidogenic areas because of the accumulation of the cholesterol. So what are the steroidogenic areas? Obviously we know one is the adrenal gland and second is the gonads. Both are going to be destroyed over time. But please understand the fact, only steroidogenic areas that are very active in the embryonic life is going to be destroyed in the embryonic life itself. But steroidogenic areas which are not active in the embryonic life will be destroyed later when they become active. Because only when they become active, they need a lot of cholesterol. When they are not active, that 17% reaction speed itself is more than enough for them. When they are active, they accumulate cholesterol. So what are the areas that are active in the embryonic life and in the fetal life? So we know that the fetal zone is the one that is highly active in the fetal life. So that is the first thing to be destroyed. But remember, usually the definitive zone escapes. Definitive zone usually is not so active in the fetal life. So, I mean, after birth only the definitive zone will become active. Again, I have given these basics in the previous videos itself. So it will be destroyed later in the puberty only, because this definitive zone is not so important in the fetal life. So that will be, like usually naive. Only in the later in the childhood and in the puberty time, this definitive zone becomes active and explosive, and that time it needs more influx of cholesterol. That time without star, they cannot put this sufficient cholesterol into the mitochondria, so they start accumulating and they will be destroyed in the later life. Gonads depends. Usually male gonads are very, very active in the fetal life because they have to produce testosterone, then only they can virilize the child and become a male. So usually the testis will be usually destroyed in the embryonic and fetal life itself. But as ovaries do survive, generally ovaries are destroyed later. they do survive for a considerable period of time because estrogen production is not very active in the fetal and embryonic life. Only at puberty the estrogen production kicks off. So usually they will be destroyed later in the puberty. So the destruction will depend on how active the gland is. So active steroidogenic areas will be destroyed immediately because of the faster influx of cholesterol. For that you need star protein, but if you don't have star protein, you will result in accumulation of cholesterol, and this accumulation of cholesterol will kill the cells and kill the gland, whichever areas that is active. So other than that, what is going to be the problem here? So obviously all the metabolites will be low. Your pregnenolone, progesterone, 17-oxyprogesterone, 17-oxypregnenolone, androgens, estrogens, everything will be low. There's no doubt about that. Your cortisol will be low. Your aldosterone will be low. So which means your mineralocorticoid levels will be low, resulting in salt wasting. Your glucocorticoid levels also will be low, resulting in a variety of problems like adrenal crisis. And these low glucocorticoids can stimulate the pituitary, resulting in excessive ACTH. And this is the reason for hyperpigmentation and adrenal hyperplasia in these patients. But because of the accumulation of lipid droplets, we are going to call it as lipid hyperplasia rather than just simple congenital adrenal hyperplasia. So what will happen to the children? What will happen to the sex? Is there any DST? Yes, there will be a DST. Remember here, there is no sex hormone production in these children. Since there is no sex hormone production in these children, there will be no androgens and there will be no estrogens at all. So this no androgens and no estrogens is not a problem in female children. These female children will have normal external genitalia at birth and normal internal genitalia at birth as well, which means there will be no DSD in these children, no ambiguous genitalia. But they can have a delayed puberty. Why delayed puberty? That is because of inability to produce estrogen. They can have a delayed puberty, like what you saw in the 17-hydroxylase deficiency. But male children are going to have DSD because these androgens are needed for proper virilization of a male fetus. So because of the loss of androgens and poor androgen production here, the male fetus will go for under-virilization. And because of the under-virilization, they will be presenting with DSD at birth, which means they are going to have ambiguous genitalia. So this is the features of star deficiency. Apart from that, your glucocorticoid will be low, resulting in adrenal crisis. Your mineralocorticoids will be low, resulting in salt wasting, and a lot of other associated problems, hyperpigmentation, elevated ACTH, adrenal hyperplasia, all the other usual issues. But it is also a condition, this star deficiency is also a condition which produces XX-DST, star deficiency is a condition which produces XY-DST rather than a XX-DST, which is very important to know. And what about this 11A1 deficiency? 11A1 is also referred to as side chain cleaving enzyme, and it's also referred to as desmolase by many textbooks. This 11A1 is very, very important for the first enzymatic reaction in steroidogenesis, where it converts this cholesterol to pregnenolone, right? So when you do not have this SEC at all, complete absence is usually fatal. Fatal in utero itself. Complete absence of this enzyme means there will be no production of progesterone. I told you the most important hormone from the placenta as well as the fetal adrenal gland is the progesterone as far as pregnancy is concerned, because this is the one that sustains the pregnancy. So when you do not have this progesterone, pregnancy will not be sustained. Complete absence of side chain cleaving enzyme will result in stillbirth, or the fetus will get aborted. They cannot survive. Clear? So because of the loss of progesterone. But partial absence, they generally escape because of good amount of progesterone that is produced. Partial absence, depending on the degree of absence, the features will vary, but partial absence will behave something similar to what you saw in the star deficiency only. Here also, your cholesterol flux will be very poor. The cholesterol will start accumulating in the steroidogenic areas, resulting in lipid hyperplasia, right? So this is also a condition that can result in lipid type of hyperplasia. But in exam, when they ask you lipid hyperplasia, go for star deficiency rather than side chain cleaving enzyme deficiency. But at the same time, all the metabolites will be low. Like obviously, this is a starting step, isn't it? Every single thing will be low, like your aldosterone output and the entire glomerulosa substrates will be low. Cortisol will be low. Entire fasciculata substrates will be low. Entire reticularis substrates and 17 ketosteroids will be low. And they will be having low amount of testosterone and estradiol production as well. And they're going to present in a very, very similar way. Like because they have low androgens and low estrogen production as well in all the ways. So this low androgens and low estrogens is not a problem in female children. at birth at least, and they will have no DSD at birth. And probably they might have a delayed puberty. That's all. They might have a delayed puberty. That's the only problem. But apart from that, there is no DSD. But male children is going to have DSD. That is because they do not have androgens under virilization. So definitely they will be presenting with a DSD at birth, because they will not be virilized properly and there will be no proper closure of the labioscrotal folds, resulting in ambiguous genitalia looking like a female. So apart from that, salt wasting, adrenal crisis, elevated ACTH because of low cortisol, hyperpigmentation, hyperplasia of the adrenal glands, same story, no, not much different. So you have seen this side chain cleaving enzyme deficiency as well. Now we are moving on to the steroidogenic defects without adrenal hyperplasia. So what are the steroidogenic defects without adrenal hyperplasia? So I already discussed 3 steroidogenic defects will not produce adrenal hyperplasia. One is your aldosterone synthase deficiency, obviously, because their cortisol will not be affected, so ACTH levels will be normal. So that's why they don't have adrenal hyperplasia. Number 2, the gonadal enzymes, if they are deficient, the pure gonadal enzymes like 17-beta-HSD3, aromatase deficiency. So if they are deficient, so you won't result in adrenal hyperplasia because ACTH levels will be normal. So let us see 17-beta-HSD3 deficiency. So 17-beta-HSD3 is very, very important for converting this low potency androgens to high potency androgens like testosterone, right? So if you have a 17-beta-HSD3 deficiency, your testosterone production will be extremely low, but estradiol production will not have any problem because that is done by a different isoform called isoform number 1. So testosterone production will be seriously impaired. But apart from that, your entire adrenal gland is normal. Your aldosterone production is okay, cortisol production is okay, and DHA and A4 production, 17-ketosteroid, that is adrenal androgen production is completely okay. And because cortisol is okay, your ACTH is okay and normal. So which means there is no hyperpigmentation and no adrenal hyperplasia as well. But this is a condition of a DSD only. So which means who's going to go for DSD, because this is a condition of low testosterone only. So only the male children will be affected, which means it's a condition of a XY DSD. Not similar to what you saw in side chain cleaving enzyme deficiency, but side chain cleaving enzyme in star is also XY DSD only. But similarly, this 17-beta-HSD3 deficiency is also a XY DSD and not a XX DSD. And female children will be completely normal. And the adrenal function, as far as these children are concerned, will be completely normal. Clear? In severe conditions, they might be completely female looking also. Completely female looking may be there if it's a complete absence of 17-beta-HSD3. Because if you have no 17-beta-HSD3, you cannot produce testosterone. If you cannot produce testosterone, you cannot produce dihydrotestosterone as well. And dihydrotestosterone is very, very important for virilization of the external genitalia in a male child. So which is needed. So to cause the labioscrotal fusion and to produce scrotum and all this stuff. So if it's not there, your external genitalia will completely look like a female. So in full deficiency, the entire genitalia may look like completely a female. That's why it's a condition of a XY DSD and not it will not produce a XX DSD. So clear? So this is what happens in a 17-beta-HSD3 deficiency. Then we have aromatase deficiency. We know aromatase is an enzyme that is going to convert this androgens to estrogens. But if you have a low estrogen, you don't have any problem in a female child. And obviously testosterone is normally produced and you should not have problem in the male child as well. But what if I tell this aromatase deficiency is going to produce a XX DSD, which means it's going to cause virilization of the female child. So how does this happen? So remember, to understand this, you have to understand the importance of the placental aromatase. Because placenta is coming from both fetus as well as maternal sides. But this fetal placental side has a lot of aromatase activity. Why fetus has a lot of aromatase activity, especially the placenta? Because the mother tends to produce androgens as well. So the lot of androgens are coming from the mother side and lot of androgens are coming from the fetal adrenal gland as well. Fetal adrenal gland is also producing a lot of androgens in the embryonic and fetal life. So these androgens, especially if it's a XX fetus, to protect this XX fetus from the harmful effects of androgens coming from mother and from the fetal adrenal gland. So they generally tend to convert this to estrogen. And this estrogen will be circulating in the maternal blood. And that's why I told you in the basic video itself, like 2 videos before, almost 50% of the circulating maternal estrogens is coming from the fetus only. So that placental aromatase activity. So this is one of the main problem here. Suppose if you have an aromatase deficiency in this fetus, the placenta doesn't have aromatase, your maternal androgens as well as your adrenal gland androgens cannot be converted to your estrogens, which means that will result in 2 problems. One, the maternal androgens also will increase disproportionately compared to that of estrogens, and the fetal androgens also will increase. So this increase in the maternal androgen will result in one important clinical clue. This is what I have been telling for long from the first video itself. That is, they will have a maternal virilization. That history of maternal, especially that perinatal virilization, is a very, very, very important clue towards aromatase deficiency. I told you in the P450 oxidoreductase deficiency also, where P450 oxidoreductase is very important for proper functioning of aromatase enzyme as well. And this excessive fetal androgens in a male child is not a problem, because this excessive androgens in the fetal life in a male child will not result in any problem. So they will not have any DST, which means this is not a condition that produces XY DST. But in a female child, this is definitely a problem and they are going to result in a DST. That's why this is going to produce XX DST. Clear? So in a male fetus, if it's a male fetus, there will be no DST, but there will be history of maternal virilization only. But if it's a female fetus, there will be DSD in the fetus also. The child also will have ambiguous genitalia. At the same time, there will be history of maternal virilization as well. So aromatase deficiency is again unique in producing a maternal virilization along with the XX DST, but not a XY DST. The male children will be normal. But there is no problem in the adrenal steroidogenesis. Absolutely no problem, because that's why I told you everything will be normal. ASTH will be normal, cortisol will be normal, and mineralocorticoids will be normal. There is no salt wasting, and they won't go for adrenal crisis. So everything else is normal. No hyperpigmentation, no adrenal hyperplasia. Everything is fine. Only the problem is the DST. So then we have this aldosterone synthase deficiency. So aldosterone synthase deficiency, we know the problem is here, or it's called as CYP11B2. The problem is here. So that's aldosterone synthase. So if you don't have aldosterone synthase, you cannot produce sufficient amount of aldosterone. Clear? That is the main thing. So there will be low levels of aldosterone. But remember, you might assume that proximal substrates may be very high. Like your deoxycorticosterone may be very high, but it's not the case. Why? Because that is why I told you that ACTH is very important. Excess ACTH is a very important player in increasing the levels of the substrates. So here the cortisol levels will not be having any problem at all, because this aldosterone synthase is a completely different enzyme from this 11-beta hydroxylase. That's why I told you these points multiple times in the beginning. So because 11-beta hydroxylase is fine here, only aldosterone synthase enzyme is deficient here, the cortisol levels are completely normal, and that will result in a normal ACTH. Because the ACTH is normal, these patients will not have any hyperplasia of the adrenal gland. That's why it's not good to call this disorders as congenital adrenal hyperplasia in the first place. And they will not have any hyperpigmentation also. And all the other processes are completely normal. Everything is normal. They have normal production of 17 ketosteroids, and they'll be having normal production of 17 hydroxy derivatives, and they'll have normal testosterone, normal estradiol production. Absolutely no problem. Which means this condition is a condition where you do not have, in fact, a DSD at all. Which means the karyotype will, whatever may be the karyotype, there is no DST. There is no ambiguous genitalia in aldosterone synthase deficiency. The only problem these children will be facing is salt wasting because of low aldosterone. Nothing else. Crisis is also very rare. Crisis will not happen, and it's very rare. That's because cortisol levels are normal. So only if the cortisol levels are low, you will get the adrenal crisis. Since the cortisol levels are normal, usually crisis is very rare, but they generally do have salt wasting. Clear? So these are the features of aldosterone synthase deficiency, where you don't even get a DST in the first place. So finally, we are going to see certain steroidogenic defects with complete reversal of the sex, like especially XY reversal. Complete reversal means we are talking about XY reversal. So first is the NR5A1 or SF1 defect. So this is a steroidogenic defect because I told you this NR5A1, otherwise called as steroidogenic factor 1, is important for adrenal development, is important for gonadal development. At the same time, it's important for, to an extent, kidney development, but not that much. Kidney is most of WT1, so we have seen that already. Gonadal development and even pituitary development. For all these things, you need this NR5A1. The worst affected are the adrenal and the gonads. Pituitary may also be affected and they may have pan-hypopituitarism as well. But if you have a steroidogenic defect, this SF1 defect, the entire gonadal and adrenal function will be completely lost. So I can put a big cross here, which means none of this will function, which means the gonads will not function, the adrenal glands also will not function. So, but here one important problem will happen because the gonads will not develop at all in the first place. It's not like they do not produce testosterone, they do not develop at all. So here these children will generally not have gonads and will not have adrenal gland also. So since they do not have adrenal glands, they won't have any mineralocorticoid production. All the metabolites will be low. All metabolites, whatever we have seen, will be low and they won't be detectable. Mineralocorticoids will be low and glucocorticoids also will be low. Together they will result in severe salt wasting after birth and they will result in adrenal crisis as soon as they are born. But remember, depending on the severity of NR5A1, if severe enough, they can cause stillbirth also. Stillbirth, or they can produce abortions. That is because of loss of progesterone. If it's not severe enough, some adrenal is there which produces some amount of progesterone, or placenta is taking over and produces some amount of progesterone, then it's fine. So the child will be somehow born. But if in severe defects where there is no production of progesterone at all, the child will go for stillbirth and abortion in the uterine life itself. Suppose if something is there and progesterone is there to sustain the pregnancy and they are born, means they will be born with severe salt wasting and adrenal crisis. At the same time, since they do not have gonads at all and they will not have estrogens and they will not have testosterone as well. Clear? So this no estrogen and no testosterone is not a problem in a female child. In a female child, it's not, they don't care really. So they don't have estrogen, they don't have testosterone, fine. So they'll have normal external genitalia and normal internal genitalia at birth. Which means this is not a condition that produces DSD in a female, which means there is no XX DSD here. But if it's a male child, that will be definitely a problem because male child needs this gonads for two reasons. Because gonads will produce, that is the testis will produce your anti-Mullerian hormone, and testis is going to produce androgens also, which is needed for virilization. So this AMH is needed for Mullerian regression, which means your Mullerian structures should be stopped from growing, like fallopian tube, uterus and all. And androgens should be there to produce proper virilization of the external genitalia and production of male internal genitalia. Clear? But in these children, if you don't have gonads, and the gonads have gone for dysgenesis, means you cannot produce AMH, you cannot produce androgens, which means there won't be Mullerian regression. In fact, these children will have persistent Mullerian structures. Persistent Mullerian structures, which means they will have a female internal genitalia. And without androgens, they cannot produce a male internal genitalia because testosterone is needed for this male internal genitalia. And dihydrotestosterone is very crucial for virilization of this external genitalia, which will not happen. And they will also look like females from the outside, which means they will be completely females from the outside. They won't have any female external genitalia. They won't have any male internal genitalia. And the outside completely looks like a female external genitalia, which means they will be completely read as a female. But the karyotype is XY. So it's a XY DSD. Clear? With persistent Mullerian structures. Very important. So remember, this group of disorders, we call it as Swyer syndrome. So what do you mean by Swyer syndrome? Whenever there is a gonadal dysgenesis, I'm going to discuss in detail in some time. So whenever you have a gonadal dysgenesis, especially of the testis. So you will result in a XY female, which means they will be genotypically XY but phenotypically female. So this is called a XY female or a XY DSD. And if it happens due to gonadal dysgenesis, that is especially in a male, that is testicular dysgenesis, that's called a Swyer syndrome. So Swyer syndrome has multiple causes. One of the causes and very important cause is SRY mutations, where there will be poor SRY expression. Because of that, you will result in testicular dysgenesis and NR5A1. Because this NR5A1 is also a very important player for production of testis. If you don't have this NR5A1, you go back to the basics and see NR5A1 is very, very important. So if you don't have, the testis will go for dysgenesis, and your male child will look entirely like a female with persistent Mullerian structures. So whenever you have a Swyer syndrome, you have to understand that it's a XY DSD and with a persistent Mullerian structures. Clear? And with NR5A1 defect, especially remember, SRY defects will result only in testicular dysgenesis, but they won't have other steroidogenic problems. But this NR5A1 defects will result in testicular dysgenesis, that is XY DSD with persistent Mullerian structure, that is complete sex reversal. At the same time, they will have steroidogenic defects also. That is how you differentiate SRY from NR5A1 defects. Remember, SRY will result only in XY DSD with persistent Mullerian structures, but they won't have any other steroidogenic defects. Like there will be no adrenal crisis, there will be no increase ACTH, there won't be any problem at all. But this NR5A1 defects will result in XY DSD with persistent Mullerian structures. Yes, that is typical of a testicular dysgenesis or Swyer syndrome. But they will be presenting with steroidogenic defects like adrenal crisis also. That's very important. Clear? So this is the thing that differentiates this SRY from NR5A1. Both are causes of Swyer syndrome. That is nothing but testicular dysgenesis that is happening in XY males. Clear? So finally, last but not the least, this is a steroidogenic defect with syndromic features. So what are the steroidogenic that has syndromic features? That is called Smith-Lemli-Opitz syndrome. I think previously we have discussed about this Smith-Lemli-Opitz syndrome. The defect is in this place. You have a dehydrocholesterol, that 7-dehydrocholesterol, which has to be converted to cholesterol by this DHCR7 enzyme. That's called dehydrocholesterol reductase enzyme. Defect in this is what we refer to as Smith-Lemli-Opitz syndrome. So this patient will have low cholesterol, and because of the low cholesterol, they won't have lipoid hyperplasia like what you got in star defect and side chain cleaving enzyme. So because they have low cholesterol, in fact, and their 7-dehydrocholesterol levels will be very high, which is one of the important markers for diagnosing this Smith-Lemli-Opitz syndrome. And all the adrenal axis will be reduced, all the steroidogenesis will be arrested. They will have low aldosterone, they'll have low cortisol. But remember, if you do not have progesterone at all, you will not sustain pregnancy. There is some amount of progesterone that should be produced to sustain the pregnancy, and let us assume it is produced, but in low amounts. But aldosterone will be low, cortisol will be low, and these patients will have low testosterone production. These patients will have low estradiol also. So absolutely no problem about all these things. So obviously these patients will have adrenal crisis, depending on the severity, because this is a condition where they may have variable severity. So depending on the severity of the disease, they might have different presentations. So they may or may not have adrenal crisis. They may or may not have cortisol deficiency and high ACTH and hyperpigmentation. And in severe cases, they will have a DST. Remember, they cannot produce sufficient amount of testosterone, that is androgens. They cannot produce sufficient amount of estrogens as well. As we have discussed enough about this, a female fetus doesn't care a bit about this, because even if they do not have androgens or even if they do not have estrogens, doesn't matter, they will have a normal external genitalia and internal genitalia at birth. They don't care. But they may not have a delayed puberty because of the low estrogen production. Delayed puberty, right? Male children, obviously, because of the low testosterone, is going to affect the male fetus because they will go for under-virilization and they will have a DST. So this is a condition that produces XY DSD and not XX DST. Very important. This is a condition that's going to produce XY DSD and not a XX DST. Once again. But they will have syndromic features. What are the syndromic features? These are very characteristic features. One is the wide nasal bridge. You can see that wide nasal bridge is very important feature. And they can have an upturned nose. You can see in all these children there are upturned nose. Upturned nose. That's very important. That's a very important syndromic feature with Smith-Lemli-Opitz syndrome. Then what about mouth? You can see there can be a cleft lip or a cleft palate. Very common in these children. And these children also tend to have syndactyly and polydactyly. And usually polydactyly tends to be post-axial polydactyly. That's a very common form also. Remember, post-axial means it happens on the little finger side. If you have extra finger, that is post-axial. Pre-axial means that happens on the thumb side. So, or in other words, ulnar side is post-axial, thumb side is pre-axial. Radial side is pre-axial. So, if you have extra fingers on that side. So, these patients usually tend to have a post-axial polydactyly because it's coming from the ulnar side, little finger side. So, that's a post-axial polydactyly, very common in these children. And they can have clinodactyly also. Clinodactyly as well. So, there are two entities called clinodactyly and camptodactyly. So, what do you mean by clinodactyly? If there is a lateral curvature in the, in the lateral curvature, this is the palmar side. If the fingers are curved in this particular axis, in the palmar axis, so that's called a clinodactyly. In this condition, you can see clinodactyly very commonly happens in the little finger side only, and usually they will be turned towards the radial side. So this is the radial side, thumb side is the radial side. So usually the fingers will be turned towards the radial side. You can see the clinodactyly here, the fingers will be turned towards the radial side. And what do you mean by camptodactyly? Camptodactyly is not associated with Smith-Lemli-Opitz syndrome, but camptodactyly is the one that has a flexion defect. Like for example, they will be having a flexion defect, like especially at the PAP joint, the fingers will be flexed and it will be contracted at birth itself. So that's called camptodactyly. So these patients may have additional clinodactyly as well. So which means Smith-Lemli-Opitz syndrome will have additional associated syndromic manifestations, like very classically the syndactyly, post-axial polydactyly, clinodactyly, upturned nose, and probably a cleft palate. Apart from that, you might be encountering an XY DSD in these patients, but XX will be okay, but they will have a delayed puberty. But apart from that, at birth, they will not have DSD. So I can summarize and tell Smith-Lemli-Opitz syndrome patients, if it's a male, they will have a XY DSD. If it's a female, they will have delayed puberty. And they will have syndromic features, which I told you already. And they will have increased levels of 7-dehydrocholesterol, but they'll have reduced levels of cholesterol. So this is going to clinch you the diagnosis. In exam, this upturned nose is one of the very, very, very classic hallmarks of Smith-Lemli-Opitz syndrome that the examiner gives for you to diagnose. Clear? So you have seen so many disorders right now. Everything is easy if you see from the back end. So just need some proper understanding about all these things. So before going, since this is a tough topic, I would like to summarize all the findings which I have told. Steroidogenic defects can be classified based on mineralocorticoid axis. Like this is how I classify, because I like this way, because I am used to study this way. Like disorders with increased mineralocorticoid activity, disorders with reduced mineralocorticoid activity, and disorders with normal mineralocorticoid activity. So that will be easier. So we need a classification system. So first let us see disorders with mineralocorticoid deficiency rather than excess activity or normal activity. So first see X karyotype, what is going to happen, XY fetus, what's going to happen, and what is the diagnostic gold standard. So that's how we're going to classify. The first one in this group will be the star deficiency and the side chain cleaving enzyme deficiency. Both are going to behave pretty much similar in the sense that they are going to produce an XY DST, but they're going to produce only delayed puberty in case of females. That is XX karyotype. Why? Because star and SCC is on the top of the steroidogenesis pathway, which means the entire steroidogenesis will be affected. It's going to affect the gonadal sex hormone production. That's really important. Because of that, loss of androgens in males will result in DSD, that is ambiguous genitalia, and undervirilization. In females, androgens or estrogens, if they are lost, doesn't matter at all, and they will have a normal external genitalia at birth. But you need these estrogens to produce this menarche. That is puberty, you need estrogen. So you don't have estrogen, that's the reason where they don't achieve this puberty at all. So they'll have a delayed puberty. I've explained the mechanism already. Diagnostic gold standard is the fact that all metabolites related to adrenal gland will be decreased, and the steroidogenic areas like adrenals and gonads will catalytically go for these lipoid changes, which is very important and crucial for diagnosis. In biopsy, you can see that. And second one is 3-beta-HSD deficiency. We have known that they're going to produce DSD in both XX as well as XY karyotypes, which means it's an XX as well as XY DSD. And in this condition, you're going to see delta 5 delta 4 ratio, because in 3-beta-HSD, I have tried 2 enzyme, 3-beta-HSD 2 enzyme. It's important because it converts this delta 5 compounds to delta 4 compounds. So obviously, this delta 5 to delta 4 conversion will be weak and the ratio will be increased, and that's the diagnostic gold standard here, which means I'm going to take the ratio of 17-hydroxypregnenolone to 17-hydroxyprogesterone here. And number 3, we have 21-hydroxylase deficiency. 21-hydroxylase deficiency, let us assume it's a classic variety. We know very well it's a XX DST because of excessive adrenal androgens virilizing the female fetus, whereas you don't have any problem in the male fetus, at least at birth, but over time they might go for early puberty or precocious puberty. But DSD is seen only in XX karyotype. Clear? So how will you diagnose? The diagnostic gold standard is always the 17-hydroxyprogesterone. There is no doubt about that. This is the most robust test that is available for 20-hydroxylase deficiency, and we have to use it in a judicious way. And P450 oxidoreductase deficiency, it is like combination of deficiencies of 17-hydroxylase, 21-hydroxylase as well as your aromatase enzyme deficiency. So which means they're going to have XX as well as XY DSD, and both these children will have delayed puberty by mechanisms which I have described already. This is very peculiar for this P450 oxidoreductase deficiency, and there might be history of maternal virilization, which is a very important clue for aromatase deficiency, and which can happen in P450 oxidoreductase deficiency as well. And number 5, you have NR5A1, or otherwise referred to as steroidogenic factor 1 defects. You know very well this is very important for gonadal growth, and especially for testicular growth. This NR5A1 is very, very important. If you don't have this NR5A1, it is like condition that is resulting in gonadal dysgenesis. So especially testicular dysgenesis, testis is the one that is maximally affected. So they go for XY DSD, where testis cannot produce androgens. At the same time, testis cannot produce estrogens anti-Mullerian hormone as well. Because of that, there will be persistent Mullerian structures. Very, very important point. They'll be having persistent Mullerian structures as well. And this is not seen in other conditions. This, among the steroidogenic defects, this is very important to understand. And in females, they will just present with a delayed puberty, nothing else, because of estrogen loss in the females, because the ovaries cannot produce estrogen, because it's like a gonadal dysgenesis. And all the metabolites related to adrenal gland will be reduced, and this is a very important clue that differentiates from SRY defects. SRY defects will have normal adrenal function and they'll have normal adrenal metabolites. So in this condition, they'll affect both adrenals as well as the gonads. Number 6, there is a condition called aldosterone synthase defect. We know aldosterone synthase is not going to cause adrenal hyperplasia itself in the first place, because it's a pure mineralocorticoid problem. It doesn't affect the cortisol at all. So which means there will be no DSD, which means the children will be completely normal with pure salt wasting, nothing else. And even crisis is very rare, which I have told you already. The condition that produces only pure salt wasting, and there will be no adrenal hyperplasia, and the patients will be not having any hyperpigmentation as well, which is due to normal ACTH, which in turn is due to normal cortisol, which means it's a pure mineralocorticoid related issue. That's what you have to understand. This is aldosterone synthase deficiency, and there will be no adrenal hyperplasia in aldosterone synthase deficiency. So number 2, we can write as second classification I told you, those with mineralocorticoid excess states, which means they will have hypertension at birth at least. There are 3 conditions. One is this 11-beta hydroxylase deficiency. Second is this 17-hydroxylase deficiency, and third is this 11-beta hydroxysteroid dehydrogenase 2 deficiency, HSD2 deficiency. But whenever in exam you think about hypertension, there is one small clue is there, which I used to remember. Remember, the first number is always 1. Anything that produces hypertension and excess mineralocorticoids, the first number is always 1. And don't confuse with this aldosterone synthase, because aldosterone synthase other name is 11B2, isn't it? It's 11B2, but no need to worry about that. So this 11-beta hydroxylase is 11B1. In exam, usually they will ask this 11B1 only. Aldosterone synthase is very, very rare in exams. Clear? But apart from that, in exam, you can simply remember anything that starts with this letter 1, number 1. Number 1, 11-beta HSD2, 11-beta hydroxylase, 17 hydroxylase. The first letter is 1. They'll come with high mineralocorticoids. That is hypertension. Clear? So what will be the DSD? We know that 11-beta hydroxylase is going to behave like 21 hydroxylase only, with the exception that they have hypertension. Apart from that, they are almost similar to 21 hydroxylase deficiency, which means they are going to have a XX DSD, whereas XY karyotype, these male children can go for a early puberty like 21 hydroxylase. But the only difference with 21 hydroxylase is hypertension, most important difference, and that is because of elevated deoxycorticosterone at birth. Even though these children at late infantile period, they can even go for crisis, because this 11-DOC is not enough to sustain the mineralocorticoid axis for a longer time. But at birth, at least they will be hypertensive and they will have elevated DOC. And 17 hydroxylase, we know it's going to cause a XY DSD, but only delayed puberty in case of a females. It's due to like androgen and estrogen loss. Androgen loss is the reason for XY DSD, and estrogen loss is the reason for delayed puberty. But androgen loss or estrogen loss will not cause DSD in case of a female child with XX karyotype. And what is the diagnosis? Diagnostic gold here is the patients will be coming with hypertension because of mineralocorticoid excess. And what are the mineralocorticoids that are increased? DOC and corticosterone. Both will be increased. Clear? Aldosterone levels will be decreased. But remember, in 11-beta hydroxylase deficiency, only deoxycorticosterone will be increased, but corticosterone and aldosterone will be low. But in this condition, in this 17 hydroxylase deficiency, deoxycorticosterone as well as corticosterone will be high, but aldosterone levels will be low. What about this 11-beta HSD2 deficiency? Remember, it is a peripheral defect. It's not an adrenal defect in the first place. It's a completely peripheral defect which affects cortisol to cortisone conversion. Cortisol to cortisone conversion in mineralocorticoid responsive tissues. In mineralocorticoid responsive tissues, this is very important because this prevents the cortisol from binding with the mineralocorticoid receptor. If this doesn't happen, then cortisol will bind the mineralocorticoid receptor in mineralocorticoid responsive tissues, resulting in hyper aldosteronism-like features that will result in a condition called SAME. That's called syndrome of apparent mineralocorticoid excess. So which means it's a pure mineralocorticoid problem, which means there is no problem in the gonadal or other adrenal axis in the first place. So which means there will be no DST, there's no problem in the androgen or estrogen. So everything is normal. This patient is coming with hypertension with no DSD. And how will you evaluate? You have to see the urinary cortisone to cortisol ratio, urinary cortisone to urinary cortisol ratio, which will be grossly decreased, because here the cortisol to cortisone ratio is, cortisol to cortisone conversion is very, very poor, resulting in very low levels of cortisol and high levels of cortisol, resulting in the ratio being very, very low. Clear? So third way of classifying is with normal mineralocorticoid axis, which means the mineralocorticoid pathway is completely normal. Still you have a steroidogenic defect, which means the problem must be in the gonads. That's all. So what are the problems? You have 17-beta HSD3 deficiency, number 1. So this is the problem with conversion of your dehydroepiandrosterone and androstenedione to testosterone, which means this enzyme is very important for converting weaker androgens to stronger androgens, which means they are going to present with a XY DSD where the females will be completely normal. So females don't have any problem with this. Here the diagnosis is based on androstenedione to testosterone ratio. I'm going to take androstenedione testosterone ratio, which will be increased here, because this androstenedione to testosterone conversion is mediated by this 17-beta HSD3, which is not happening. So testosterone will be very, very low, but the androstenedione levels will be very, very high. So that is the diagnostic point, and it's an XY DSD. And aromatase deficiency, we know the placental aromatase is the one that converts maternal as well as adrenal androgens to estrogens that is circulating in the mother side. So obviously this will result in a XDSD, but whereas XY fetus may go for early puberty in case if they have a significant amount of aromatase deficiency. Apart from that, XY will generally be normal. It's a DSD of a XX karyotype. It's an XX DSD. Only the female fetus or female children will go for virilization. And very important history is the history of maternal virilization. Is a history of maternal virilization, which is very, very important. Clear? So these are the nutshell of all the DSDs which we have discussed. So I think, like now it will really make sense and it's very easy to understand. But in exam, still students do tend to ask some mnemonics from me. And the students wanted some final nutshell, and if I know this, I have to answer. Very simple, I'll give a small flowchart for you. So any children with a DST, or otherwise I can call it as an ambiguous genitalia in your terms. But I generally like to call it as a DST, disorder of sexual differentiation. And if you suspect CAH, CAH is suspected in exam, especially when the child is having hyperpigmentation. Whenever the child is having hyperpigmentation in exam, it's a clear-cut, straightforward indicator that the child is having a congenital adrenal hyperplasia. So when you are suspecting a CAH, now next step is to see the BP, blood pressure. So if the BP is increased or BP is decreased, hypotension and shock. If the BP is decreased, very simple, I'm going to see the 17-hydroxyprogesterone levels. If the 17-hydroxyprogesterone levels are grossly increased, I know very well this patient is suffering from a classic 21-alpha hydroxylase deficiency. Very, very important point. Clear? Obviously. If the 17-hydroxyprogesterone levels are only normal or only mildly increased, normal or only mildly increased, this is suggestive of a 3-beta-HSD deficiency, usually. This is suggestive of 3-beta. We know that. So in 3-beta-HSD deficiency, it will be just mildly increased, but they will be presenting with crisis only, adrenal crisis and shock. BP will be low. So in this setting, if you want a definitive confirmation that it's a 3-beta-HSD deficiency, you have to go for ratio of delta 5 to delta 4 compounds in the plasma and in the urine. So which means I'm going to take a 17-hydroxypregnenolone to 17-hydroxyprogesterone ratio, which will be grossly elevated. But there will be only normal or mild elevation of the 17-hydroxyprogesterone in this condition. I'll tell you one more clue in some time. So if BP is increased, once again see the 17-hydroxyprogesterone levels. If it is 17-hydroxyprogesterone, if it is increased or if it is decreased. If 17-hydroxyprogesterone levels are increased, means it's a 11-beta hydroxylase deficiency, or simply I can call it as 11B1 deficiency in the zona fasciculata. If 17-hydroxyprogesterone is decreased and the patient is having a hypertension, usually it means a 17-hydroxylase deficiency, because with the 17-hydroxylase deficiency, you cannot produce the 17-hydroxy compounds at all. And you cannot produce this 17 ketosteroids or any 17-hydroxy compounds, and 17 base compounds cannot be produced. That's why 17-hydroxy derivatives will be reduced in 17-hydroxylase deficiency, for sure. But what are the clues here? So remember, even though the BP is high, in 11-beta hydroxylase deficiency, your DOC levels will be increased. You know that very well. But your corticosterone levels and aldosterone levels will be low only. I told you multiple times. In 17-hydroxylase deficiency, you know your DOC levels will be high, your corticosterone levels also will be high, but your aldosterone levels will be low. So this is one more clue. But still, you want a very easier clue. Let me tell you. Usually, we know in a 21-hydroxylase deficiency, it will be a XX DST. Clear? Which means only female children will be having DST. If they tell a female child with ambiguous genitalia, sometimes examiners may be very liberal. If they give a female child with ambiguous genitalia, it's a XX DSD, usually go towards a 21-hydroxylase deficiency. Clear? Or if they give a male child with DST. Clear? Or if they give a XY DST, or if the examiner clearly gives a male child with a DST, and if you have hypertension and all, your solid answer must be 17-hydroxylase deficiency. There is no doubt about that. And female, that is XXDSD, can be seen in 11-hydroxylase deficiency also. But you know very well, these conditions can be easily differentiated in exam, even though both 11-hydroxylase as well as this 21-hydroxylase produces this XXDSD in female children with ambiguous genitalia. So you are going to have hypertension with 11-hydroxylase and hypotension and shock with 20-hydroxylase. So there is no doubt about that. So this is a XXDSD with hypertension usually goes towards this 11-beta-hydroxylase deficiency. But remember, this 3-beta-HSD, you can have either a XXDSD, this is quite confusing. You can have a XXDSD or a XYDSD. That's why examiner usually will not ask in exam. Clear? So these are some of the very, very important points. So XXDSD, see whether it's a patient is having hypertension or hypotension. If it's XXDSD with hypotension, go for 20-hydroxylase. If it's XXDSD, that's female children with ambiguous genital with hypertension, go for 11-hydroxylase deficiency, 11B1 deficiency. If it's a male children with DSD, then think about whether it's hypotension or hypertension. If male child with DSD and if it's hypertension, go for 17-hydroxylase deficiency. If it's male child with DSD and hypotension, go for 3-beta-HSD deficiency. So this is how you want to classify. So these are the simple clues. So sir, even this I feel difficult and I want a even more easier clue. This is a USMLE clue. Usually we used to teach for USMLE students where you have this CAT, C and A and T. We write this CAT. A stands for aldosterone here and T stands for testosterone here. C stands for type of congenital adrenal hyperplasia, CAH type. So there are 3 CAH type, isn't it? So we have this 21-hydroxylase deficiency, 11-hydroxylase deficiency and 17-hydroxylase deficiency. 3-beta I'm not going to write. So wherever one is there, you put increased arrows. That's all. Clear? So which means wherever you have increased arrows means, so this patient with 21-hydroxylase deficiency is going to have excessive adrenal androgen production. Not really testosterone, excessive adrenal androgen production. But they will not have excessive aldosterone. In fact, they will have reduced aldosterone only because you don't have one there. And in patients with 11-hydroxylase deficiency, they will have excessive aldosterone. At the same time, they will have excessive adrenal androgens as well. So whenever you have excessive adrenal androgens, they are going to result in XXDSD. That's a female child with ambiguous genital, not a XYDSD. In a 17-hydroxylase deficiency, they have excessive aldosterone, which means they are present with hypertension, not salt wasting. And here, the androgens will be low. The androgen production and the testosterone will be low because you don't have one there. So that is the reason they present with XYDSD and male children with DSD, ambiguous genitalia. Clear? So this is a very simple mnemonic. This is a very old USMLE mnemonic which we used to learn ages ago. Like when I was preparing for USMLE, I used to learn this in a very simpler way. Wherever you have one, you just put increased arrows. You write CAT and you put increased arrows. That's it. So I think with this, the DSDs must be straightforward and DSDs must be very easy. And the most important thing that you have to know in this entire chapter is the 21-hydroxylase deficiency. After this, remaining all these things, you can, give a little bit of liberty and you can try learning. But if you cannot learn, it's okay. It's a very complicated topic, I understand, but I've tried my best to simplify this. And with this, I think we can close down this chapter. In the next section, we're going to discuss on the DSDs.